Hello everyone, and welcome to our Cardiovascular Imaging Conference. It's a pleasure having you with us today. I'm Dr. William Zoghbi, Chief of Cardiology here at Houston Methodist. And today I will be discussing a topic that is very dear to my heart and actually very exciting over the years, seeing the field of echocardiography and contrast evolve over so many years with its applications in cardiac ultrasound. So what we will discuss today is all these ultrasound enhancing agents and the technique that we will be using, the impact on diagnosis as well as clinical management. So let's go ahead and get started. One, I think we cannot discount the use of agitated saline in echocardiography for detecting shunts. And I want to spend a little time here just to reflect on it a bit, the differentiation between patent foramen ovale or atrial septal defects versus pulmonary AV shunting. We see still some of the issues of diagnosis, differentiation between the two. Remember one thing, just like in this case here, that a PFO is usually episodic as well as atrial septal defect. The contrast, you'll see that coming episodically, may come early or with Valsalva or otherwise, but at times may come late, depending on when this difference between pressure gradients of the right atrium and the left atrium occur. So you got to be very careful about that, as opposed to the pulmonary AV shunting where it occurs always late, and it's a continuous infusion of contrast that you will see that accumulates over time. So keep those in mind when you're trying to differentiate that, because I still see quite a few of these misinterpretations that you see at times in the echocardiography laboratory. We use agitated saline to enhance, Doppler, and we enhance Doppler for estimation of pulmonary artery systolic pressures, as you could see here. And actually, even a very tiny tricuspid regurgitation jet may be enhanced well with agitated saline or the newer agents for determination of such. Now, many factors affect bubble robustness. I think obviously over the years we've used saline agitation, and then with the newer agents that we will discuss also with you, the robustness of these bubbles are one, their size, two, the shell that is composed of these bubbles, and three, what is the gas, usually high molecular weight gas that is employed for these bubbles to withstand very high pressure coming into the left ventricle, but in addition to be able to pass the pulmonary circulation. In yellow are the agents that are available for use in the United States, and you could see their size. They are certainly less than 10 microns, in between 1 and 4 or 5 microns. The shell composition, either albumin or the newer ones, lipid monolayers, and the gas is usually a perfluorant or hexafluoride, a gas that is inert and also very safe to use. Now, the interesting thing for all of us to remember is that when you use contrast as an injection, diluted injection, the ultrasound settings, also can interact with these microbubbles. And usually we don't show, difficult pictures that you could see on the left side here, but you could see the power of using contrast to enhance visualization of the left ventricle or whatever chamber you're really interested in. So the power of such is amazing, and I think the push for utilization, appropriate utilization of contrast, is really to enhance the quality of the images that you're seeing in an echocardiography laboratory, and to change an uninterpretable study into something that is interpretable. Now, when you use such agents, obviously they will come from the right atrium, right ventricle, all the way to the left ventricle. So you have to be very careful as to the speed with which and some of the dilution that usually occurs, so to prevent attenuation. And why attenuation occurs? Because if you have a very high concentration of bubbles, it acts as a reflectant medium and it would reflect most of the ultrasound so that you won't see anything behind it, behind that wave of high concentrated contrast. So let's take a look in this image here. The contrast is injected on the right side. Left side is starting to fill, but this is a large and rapid bolus injection. Initially I see nicely, but now you start to see the shadowing because this wavefront here has a very high concentration of contrast. So when you see something like this, contrast and then shadowing or significant attenuation behind it, you know that you're dealing with a much larger concentration of contrast that went into that particular chamber. Now, the interesting thing, which is also unique for echocardiography and contrast, is that these agents interact with the settings on the echocardiography instrument and with a higher energy, and the energy is a mechanical index with a peak negative pressure divided by square root of the frequency. Basically, if you have a very high negative peak pressure, relatively very high, these bubbles will distend and will burst. So certainly if you're using then a very high mechanical index, and we'll talk what a high mechanical index is greater than 1, and you see those usually displayed on the screen, upper right or upper left of your screen of the echocardiography machine, you'll notice that the power would be very high, and therefore if you inject any contrast agents, they will be highly destroyed and quickly destroyed and won't give you the visualization that you'd like to see. So we use medium power to lower power and MI in the 0.3, 0.2 range, even at times 0.1, to preserve the bubbles and at the same time be able to enhance it very nicely. Now, the interesting thing also in this case here is I will illustrate the effect of mechanical index displayed right here. You see an MI of 1.5, and then we're going to gradually decrease this MI 1.5 to down to 0.3, and you'll see the difference in contrast within this ventricle. Initially, the contrast is being destroyed, so you're going to see almost like a hurricane here, some darkness in addition to the bright ultrasound that is reflecting, bright agents that is reflecting the ultrasound. And you'll notice as we decrease it, that the effect, here you go, you can see that it is not opacifying the whole ventricle. But as we start decreasing this MI to 0.7, 0.5, 0.4, you could see a nice opacification. So this is playing again. So the message here is if you're going to use contrast, make sure the settings, and nowadays you could automate the settings for contrast visualization to decrease the mechanical index to be able to opacify and destroy less of the contrast agent. Notice here, these are two examples for you of significant attenuation, meaning that the contrast itself is quite highly dense, and you're not going to be able to see the structures below. You're not able to see the left atrium in this situation. Now, the interesting thing is that part of the development of contrast agents to enhance and see better with contrast is the utilization of harmonics. So when usually fundamental frequency is the initial frequency that is emanating from the transducer, but as this frequency hits certain structures, it's not only it's not reflecting only the fundamental frequency, but it can reflect also multiple of that frequency, the second harmonic or even third harmonic. The interesting thing is that these tiny microbubbles reflect a lot of the second harmonic. So if you set your transducer to image in second harmonic, you're going to enhance so much the signal that is coming from the contrast itself. Now, along the development of second harmonic and its utilization, we found out that also the second harmonic is not only emitted by the microbubbles themselves, but also by the myocardium, and that's why we use it most of the time nowadays. But remember that it certainly enhances the signal coming from these microbubbles because they resonate so much and they emit quite a bit of that second frequency, second or multiple of that frequency of the original frequency. So let's show an example here, okay? So here, this is fundamental frequency of 3.5 megahertz. I'm going to show you contrast with it. Even in this still frame, you could see that there's no differentiation between the contrast and the myocardium per se. And we'll switch on and off a harmonic versus no harmonic, and you'll see the enhancement of the contrast image during this situation here. There you go. Harmonic on, and harmonic off. Harmonic off, harmonic on. And notice, contrast is so much enhanced, and you could differentiate it nicely from the myocardium per se. So some of the clinical applications of contrast echocardiography and ultrasound enhancing agents is, and this is the one that is actually FDA approved, is in improvement in endocardial border definition for assessment of regional and global function. And if you have 2 or more of the myocardial segments that are not visualized, this is the current indication. These are off-label indications for enhancement of Doppler signals, myocardial perfusion, and even in therapeutics, and we'll talk very briefly about them. For reference to you, there are 2 documents, but this is the lower one is the most recent one. These are from the American Society of Echocardiography about the clinical applications of ultrasound enhancing agents, and I think these are very good references for you, and they're still very relevant. Now, in clinical applications, if you think about, the most important one is the improvement of endocardial border definition. With that also comes delineation of hypertrophy if you're not seeing well. Truly a rescue of uninterpretable studies, particularly in intensive care units. This is an off-label indication, stress echocardiography, because you're still looking at regional as well as global function. Definition of structural abnormalities, particularly if you're wondering about if there is a thrombus or some communication like a pseudoaneurysm. So let's go through some cases here. Before that, this is actually the appropriate use guidelines from the various societies telling us that appropriate use of contrast is if you need enhancement of these images for you to be able to do that. If you're seeing all the segments of the heart, you certainly don't need to use contrast. So some examples here. One, I like to show that in a 9-frame kind of display, because no matter how you look at this heart, you barely can see it. And you could decide for yourself. I think the most important decision is here really an uninterpretable study, because you cannot tell whether even global function is normal or abnormal. You enhance the images with contrast, and you could see that indeed this heart is completely normal function, regional as well as global function. Notice in this case here, for example, again in a 9 display, show you that yes, I can understand and I can interpret a significant depression in ventricular function. Hard to tell all the wall motion, whether it's all of it is abnormal, yes or no, but I cannot tell more than that. This is the same case, showing that indeed there's diffuse hypokinesis in some akinetic segments, but on top of that, there is a nice thrombus in the apex that will change clinical management on this patient and putting them on anticoagulants. Notice this case here, for example, also. I can tell that most likely global function will be normal. I know the lateral wall is kind of hyperkinetic. Descent of the base is decent. Do I know what's going on in the apex? I'm really not sure. Is this an akinesis or is still normal? I don't know if there's hypertrophy. And notice here with contrast that this is actually one of our hypertrophic cardiomyopathy cases. You could see the septum, which was significantly underestimated before, hyperdynamic function, and a little hanging of the apex in this particular case. Another case here, the image is a bit granular, but overall looks like function is decent. Can't tell really what's going on here. My eye kind of joins the various dots and say, well, normal overall heart. This is one of the interesting cases. I keep showing it because at times there are some very unusual situations where you have an aneurysm in the middle of the anterolateral wall as opposed to distally. And this was completely missed by myself. Why? Because I connected these dots here, and this is actually where the dropout was felt to be still normal. And therefore, this is the power of such a tool, is to be able to see much better, so therefore you can understand or evaluate regional function in addition to global function. A case here came in with chest pain overnight. You could see the electrocardiographic abnormalities, and you could see the deep T-wave inversions. Is this ischemic, yes or no, or is this a hypertrophic state? Don't know really. Is this LVH? It doesn't look typical for left ventricular hypertrophy per se, the garden variety, but this is your resting echocardiogram. Hard to tell regional function well. Maybe there's a problem in the apex, I'm really not sure, but it is suspicious and could conceivably evoke the abnormality, which are rather diffuse and maybe apical. Lateral wall appears fine. If you use contrast, you notice a major difference. The diagnosis is all different. The base is not hypertrophied, and you could see an apical hypertrophy, apical hypertrophic cardiomyopathy with some sequestration of the tiny tip of the apex and complete obstruction of the distal third of the ventricle. Notice this case. Great case here, showing few things. One is that ventricular function is not normal. You could see an abnormality, definitely an akinesis of the inferior wall. The others are hypokinetic. I don't see anything else really major difference, right? So you can estimate ejection fraction. There is regional and global dysfunction. Notice with the use of contrast, two things going to happen. One is an apical abnormality that I really was not too cognizant of. There's no question about that. Two, on the two-chamber view, I could see a thrombus at the tip of this heart, and this changes my overall interpretation of regionality, that you have multi-vessel disease here in this individual, and on top of that, an apical thrombus that was there. So very interesting kind of situation. It just tells us also that we may not settle for just seeing the majority, only the majority of wall motion to be able to do a full interpretation. How about this individual? This individual has an interesting wall motion. You could see hypertrophy here, the base of the posterior wall, not that hypertrophied, but an interesting wall motion here, meaning the outside of the heart is not contracting as well, is not moving inward. Do I have more muscle? Is this an apical hypertrophy, or is this an akinetic apex? But I don't see a cavity here. I'm suspicious of an apical hypertrophic cardiomyopathy, but not completely diagnostically full-fledged. And you could see them very nicely here, that you have an apical hypertrophic cardiomyopathy. You can see many of these arterioles that actually coming in this very thick heart, very small. It's not a complete entrapment, but very small cavity all the way to the apex. And just to close the technical things here, if you will, notice few things on that same case that I showed you before. This is here an example of what? Of attenuation. This is early on. A lot of contrast actually coming in. You could see attenuation behind it, so it's not too little contrast. You can see the thrombus, still attenuation here, and this is what? This is a high mechanical image, a high mechanical index image, where you're destroying quite a few of these microbubbles. You see this hurricane-like, and much of the destruction is very closer to the transducer itself, so you could see it. Once you see this, you know that you're dealing with a high mechanical index or very low contrast coming in. However, here I can differentiate it because my input function is still pretty good. I see a lot of contrast coming in. Most likely that's a high mechanical index situation. Okay, so this is obviously off-label, is enhancement of some of the Doppler signals. And this is an aortic stenosis patient that, the CW recording of the continuous wave Doppler is not the greatest, and we wanted to enhance it a bit. We want to make sure that we're not over-enhancing it, so we wait a little bit. And you could see a very nice display. It's not blooming, and I think it is very nicely displaying the situation here for an aortic stenosis. Now, some of the utilizations of contrast is, I mean, this is an old slide, but has not really changed much. Much less likelihood of using in outpatients or ambulatory, more inpatients. They're sicker, harder to image, instrumented, particularly the ones in the ICUs. Stress echocardiography, we know that there's a decrement in image quality during stress, be it pharmacological or exercise. So if you're starting with an image that is not pristine, you want to make sure that we use contrast for enhancement, and we'll share some of these data with you. So in the ICU, the enhancement of such with contrast is almost similar to what you get by transesophageal echocardiography for visualization of endocardium. So we know it is very powerful. For stress, I think, as I said, you want to make sure that you have a full display of, if you want to decide, you have to decide early on use of contrast, otherwise it's going to look really funny, and you won't be equipped to be able to use the contrast on time. So make that decision early. If you're going to decide on contrast, use it throughout, from rest all the way. This is a dobutamine, a nice enhancement of ventricular function all the way down. Contrast this with this individual who has up to 10 mics per kilogram of dobutamine, a very nice hypercontractile response, but at a maximal dose of dobutamine, ventricular function goes down significantly, significant ischemia in this individual. All right, so in stress echocardiography, current utilization is almost everywhere in the United States. Has not changed much, actually. More people are using contrast appropriately, which is, I think, is important because it is a message of quality. Appropriate utilization is very important because, as you could see, it is very important to come up with a diagnosis as opposed to leave it as a diagnosis of technically difficult study. I cannot evaluate regional or global function. And who are the patients who benefit and who's the most cost-effective way? We did a study, a randomized trial, when Juan Carlos Plano was with us several years ago, on patients undergoing dobutamine echocardiography and having two studies, one with and one without of contrast, and looking at the impact of that. And you could see the impact of visualization at rest, 94% of good visualization that is maintained during stress of dobutamine. And notice, as I told you before, that image quality will go down irrespective of the stress modality that you're doing, because patient is usually breathing a little harder or discomfort or something like this. So I think it maintains the quality. And more importantly, similar to the recommendations by the FDA of greater than 2 segments not visualized, this is where the impact is the most. If you don't have assessment of regional function, you're going to miss a disease. If you have decent visualization, 1 or 2 segments or all segments visualized, I think you'll be able to do well from a diagnostic point of view. A case in point here, take a look at these on the left side. This is from that study, actually. So this is the same patient on the left and on the right. No contrast on the left. What can you say about this dobutamine echocardiogram? This is baseline, 5, 10, and 30 mics of dobutamine. I can tell you what can I say, as I see an abnormality in the apex probably at 10. At 30, I can see that. The base looks fine. I cannot tell the apex well. And that could be my diagnosis, meaning conceivably some ischemia in the apex. Let's see what you see here. Well, interestingly enough, number 1 is that this individual had a previous infarction. So at baseline, this wall motion that we suspected was mostly during stress is actually present at baseline. And notice what happens during stress. There is a larger ischemic area. This is at maximal stress, and you could see that progressing gradually from 5, 10, all the way to 30 mics in this individual. So the interpretation is very different. The extent of ischemia is different. And this individual had a baseline abnormality even to start with before the stress. Few cautions when you use contrast is the first caution I would say, if you have really pristine images in the views that you want to get, you don't need to use contrast. I think realistically in our laboratory we use contrast in about 70 or 80% of the time, depending on the initial quality of the echocardiogram. And the reason for it is you may have some decrement in the quality if you start with pristine, beautiful, excellent quality images. And also there are some artifacts that you need, and shadows that you need to be careful of, and this is an example of such. See this linear structure that you could see shadowing? Actually the endocardium is just behind it. So you have to be very careful when you use contrast and you start seeing some linear structures. The heart is not linear, meaning straight linear, I would say, not curvilinear. And the endocardium is actually behind it. And this is the same case that you could see, again, this is a magnification in the two-chamber view of this linear structure. So the endocardium is behind it. And at times, here, you have some of that here in the posterior wall, in the infero-posterior wall. So you got to be very careful where the endocardium is when you use contrast, and watch also attenuation from the parasternal window when you get to your parasternal window. So ultrasound enhancing agents in stress. One, it improves endocardial border definition, no question about that. It translates into improved accuracy, and the utilization is probably somewhere between 50 and 80% depending on the population that you serve, right? So keep in mind the baseline study. If you're struggling in acquisition or interpretation, either of these two, use contrast. And you still need optimization of the image once you do the contrast, because the windows may be a little different for acquisition, for enhancement, and lack of foreshortening of this ventricle when you see it. What's the impact on diagnosis and management? This is from Dr. Kurt, who's now practicing, I think, in Turkey. I have not seen him for some time, and he did that when he was visiting. This is a great study that he did. More than 600 patients were looking at the impact of clinical decision making and management in such patients. So they were in the either on the wards or in the intensive care units on the outpatient, and always the use or non-use of contrast is given to the sonographer. So they're deputized to do that. And you could see in red, basically very technically difficult study. That's by definition. When you use contrast, yes, it is all blue, all adequate, except in some situation, particularly in the surgical intensive care unit, or in some, so it is not 100%, but certainly it changes quite a bit of that adequacy of interpretation. And the impact is TE avoided, because they needed to know what ventricular function is particularly in the intensive care units. Nuclear imaging to address whether global function is good, yes or no. And so you could see the majority of impact is in either intensive care units or the inpatient, much less in the outpatient setting, but still an impact. So you have to make that judgment. And the impact on medication change, at times anticoagulation is stopped because it was an artifact and was not really a thrombus. At times anticoagulation is started because you see a thrombus. Hemodynamics change, particularly ventricular function, if it is super good or actually very depressed. So this is the overall impact here. The highest impact is about 60% is in the surgical intensive care unit. Second is medical intensive care unit, therefore inpatient wards, and in the outpatient unit is about 12 to 13%. And that was then, I think the data is still valid nowadays, and I think our utilization is about the same. And the worse, if you cannot see more, the impact is more. So here, 7 or so, almost 12 segments that are not visualized, you know that the impact is going to be very high because it's really an uninterpretable study for ventricular function or otherwise. So some cases for you here to challenge you, and you decide, is this thrombus versus reverberation? Think about it a little bit. Reverberation. Now you could say, well, maybe it's not completely attached to this and you use other windows. Yes, you have to do that. Change frequencies. Yes, you have to do that. Transducer. But I think contrast certainly would be very helpful for you. Take a look at this. Thrombus versus trabeculations. Well, there's a wall motion abnormality here, and it could be trabeculations and could be a thrombus. Indeed, a layered thrombus here. There's a little surprise actually, but a layered thrombus that you could see, it is deforming the apex, thicker than usual apex, right? And very nicely layered. How about this patient? This is a technically difficult study, no question about it. So I don't think people would argue twice about using contrast in this situation. And indeed, you're going to have a bigger surprise. You know, a large mass actually in this individual, multi-lobed, you know, really very concerning for emboli and for its etiology also. So we talked about endocardial border enhancement. We talked about Doppler signal enhancement. We'll talk briefly a little bit about perfusion. Because again, it's not an indication. There is a code for it, actually, utilization for perfusion, but I think it's important to talk about it because there was a lot of investigations here and just think a little bit about the myocardial vasculature, the capillaries. I mean, the speed of red cells in these is very, very slow compared to the usual Doppler speed that you see in meters per second or centimeters per second. This is millimeters. And because of that low speed, if you do continuous imaging, you're not going to see much in the myocardium. So most of these, because of their slow speed, if you do continuous imaging, even at a low MI at times, you may not see myocardial perfusion. If you do intermittent imaging or reduce the MI significantly with intermittent imaging, you may see contrast in the myocardium per se and still differentiate, you know, cavity from the myocardium per se. And this is work from Kevin Way, Jonathan Lindner, Sanjeev Kaul when they were in Virginia and, you know, continued in Portland. Really very elegant work that actually, if you take a look at, if you destroy these bubbles and you see them coming into the myocardium, that can tell you about blood volume, blood velocity, and we've done a lot of work here and many other investigators regarding what is the meaning of such, about coronary blood flow, myocardial blood flow, myocardial viability, and so many other things. So you have to use a lower mechanical index and a slow frame rate for able to do that. And you could destroy these by having a little burst of a high mechanical index and watch it gradually fill in. See here how dark it is, and gradually fill in, and can tell you about, you know, myocardial blood flow in those situations. I'll share with you an older study here. This is destruction, replenishment, and you'll see the replenishment coming back slowly in the myocardium. You could see that very nicely here. And this is during dipyridamole in somebody who has ischemia. And you could see here the higher blood flow coming into the myocardium, and you could see the ischemic region here. Notice, though, that there are some issues with contrast itself. There may be some attenuations. Here, this, you know, lateral wall, which is functioning well, is not, you know, enhancing with contrast as well. So there are some issues with that. So there is some variability and technical issues with it. So some investigators are still doing this. We're not actively involved at this stage of the game in researching myocardial blood flow using contrast, but you could see there Dr. Shimoni, Sarah Shimoni, who was with us, and many other investigators looking at sensitivity and specificity. But we have to be cognizant that indeed this work is the field of myocardial perfusion is very competitive. So yes, you could see that if and use it from time to time during a stress echocardiogram when you have contrast. But I think most of the emphasis, at least in my book, is on wall motion and global function, and perfusion may be additional, if you will, at the same time. And if we're concerned about perfusion, I think the competition nowadays is very strong. PET, Spect, and CMR is also more robust, if you will, and less technically challenging, although there are still some issues there. And last, I want to discuss something that we don't talk much about in echocardiography per se, is enhancing the vasculature, to visualization of the distal vessels, and if you have stents in vessels and in the aorta. And I think this is not in our direct realm, but I think people have used that, imaging vasa vasorum. So I wanted to conclude with a few things. One is that, and I'm personally very pleased that in the early days, and I'm talking about 15 years ago, even 20 years ago, we needed so much more education for people to understand contrast echocardiography, and more importantly, use it appropriately, because this is not revenue generating for a laboratory. The push for appropriate utilization is quality of the echocardiograms that you're getting, and also the impact, as I showed you, on diagnosis. And if you have an impact on diagnosis, you will have an impact on management. So I'm very happy and very pleased that the appropriate utilization is going on more and more, particularly in the United States and throughout the world. So I think it's important to decrease the variation. And I think that is much better nowadays. Our utilization in 3D echo has not been as good and has not been as optimized, because obviously with 3D echo you may have a little more destruction of contrast, maybe optimization of such should be a target nowadays. Why? Because 3D can give us a tremendous advantage over evaluation of global as well as regional function. So I think for this, I think we should be able to use it much better. Perfusion, we talked about it. It's technically demanding, not approved, and not as competitive with other modalities, but there is some utilization code, and it's great for research, no question about it. If you're interested in research and what areas are, if you do a certain maneuver or intervention, you could repeat this so many times, and has so much more advantage over radio-labeled microspheres. Role in therapeutics, gene delivery, thrombolysis. I think Tom Porter has been really amazing and the leader in that, and you could see some trials regarding thrombolysis and enhancement before a PCI procedure is done. And exploration and use in vascular imaging and vasa vasorum, I think this is a little bit outside our realm, but certainly we encourage our colleagues to venture there and use it, particularly our vascular ultrasound specialists and surgeons who use that technology a little more than we do. So with that, I'm going to stop here and take some of your questions. You know how to get in touch with us. If you are on text, you could text DeBakey. And if you're on the web, go to Polev and enter DeBakey and send your question. And we have a few questions here. Do you see MCE being less widely used than CMR SPECT imaging? I think I mentioned that to you. I really do think that MCE for perfusion per se will be less than CMR and SPECT. Mostly I think I see it because of two things. One is the optimization for perfusion is is a little more difficult, takes a little more expertise to be able to do that, and the variability of interpretation is a little more than I would see with CMR or SPECT or PET, particularly PET and CMR. So I could see some challenges there for MCE. And you could say to yourself, my goodness, I've used contrast already. I can look at wall motion. I could look at global function at the same time, right? why not use it? And yes, you can. The question is, what is the added benefit? Because perfusion and wall motion are closely coupled. Yes, the perfusion may be a little bit more sensitive, but they're closely coupled. So I could see a little, I mean, if the advantage is there, it may be outweighed by the variability that you're going to see. So keep it in mind. You could add it, but not sure about the overall benefit. Is MC as accurate in atrial fibrillation as in sinus rhythm? I'm thinking of, if it is for ventricular function, yes, it is as accurate and as variable as you see any function. Remember, it's going to depend on the RR interval of what your end diastolic and end systolic volume is going to be, what the ejection fraction is going to be, what your strain is going to be, if you have variability in the rhythm. And if you're talking about perfusion, I'm really not sure. I think it probably not as much. What are the advantages of contrast-enhanced ultrasound? I mean, you could see some of the advantages that we talked about. To me, the most important advantage is to render a very difficult study into a more interpretable and more accurate study. Remember one thing though, use it towards the end of your usual imaging with echocardiography. Why? Because it will take some time to get rid of the contrast. It will bloom and super enhance. You should not use it for color Doppler of jets. 2, it will mask any abnormalities that you may see on valves. So valve calcifications, a thrombus on a valve, if you will, or more likely a vegetation on the valve, that could be masked. So do whatever you need to do first. Decide if you want to use contrast to enhance either wall motion, regional, global function, whatever it is. I think these are your advantages here. Can dextrose containing solution be used for better visualization? I'm not sure about this question here, but you know, if you talk about agitated saline or any other solution, you could agitate almost anything. You could agitate the saline solution, dextrose-like solution. You could add a little blood. Actually, in the early days, it can enhance that microbubbles that you produce by agitation. So any of these, I think, would do. And with that, I think I want to thank you for your attention and hope you enjoyed it. You know, we're available on Twitter also, so you could send us any questions that you have, and I'm glad that you're joining us here for our Tuesday multimodality imaging sessions. Thanks again.